we're going to get started, yeah?
Let's do this.
Okay, well, good evening and thank you for coming. I'm Dr. Alain Polynice. Today we're going to be talking about breast implant-associated illness, but I just wanted to introduce myself for those of you who might not know me yet. So I'm a board-certified plastic surgeon, and I've been in practice now for 25 years. And 3 years ago, my wife and I and family decided to move from New York to California. It was the best thing we ever did. My wife is from California, which was always the plan to do that. And we finally made the transition 3 years ago with my daughter, who's loving it here, but just got accepted into college at Northeastern University in Boston. So she's going back to the East Coast, and there's going to be a lot of back and forth for us, I'm sure. So I wanted to chat about this topic because my practice has been always focused on breast and body contouring mostly. But in recent years, I've been seeing a lot of patients with concerns about implants. You know, attitudes have changed, you know, what people are looking for as far as body image and things have changed. But there's also been a lot of women I've seen in my practice with specific complaints of very vague symptoms. And, you know, that constellation of symptoms can be associated with implants, and that's what we're going to talk about today. So, breast implant-associated illness, it's really a term used to describe a very vague constellation of symptoms, and you can see some of them right here, from hair loss to rashes to joint pain. But this is a very short list of symptoms. If you really want the true extensive list of symptoms, these are all the things that can be associated with implants. Now, what happens is, very often, women will have a series of symptoms like this, and of course, they'll want to know what's going on, so they'll go see their primary care physician, and then they'll start getting a series of tests, and typically these tests will come back as negative or inconclusive, and it could take sometimes years before you can pinpoint what's going on, and it is often related to breast implants. The other issue is that it's very hard to sometimes get your physician to really take your symptoms seriously. And that's another big topic that we're going to talk about. But they are related to silicone implants. Now, silicone implants have been around for a very long time, introduced in the early 60s. And if you look at this, I actually didn't know the exact number, but there are 35 million implants around the world. And 2 to 4% of women in the Western world have breast implants. So they're very, very common. And if you think about the number of patients or women who have symptoms, it's very small. And maybe that's why sometimes it's discounted, and that's why it's not taken seriously. It can also be why there aren't many, big double-blind studies looking at these symptoms, because the number of patients is still very small. But that doesn't mean that the symptoms aren't very real, and that there are patients really suffering from this. So the question is, what are the causes of and what's happening? So implants are obviously a foreign body, and they can trigger an inflammatory response, but there's also a possible response from actual silicone particles and silicone material, not just a foreign body response. But there's also some individual genetic predisposition. I've had patients with a history of allergic symptoms like severe allergies who've had reactions to silicone implants. And I've had patients with COVID, which, during COVID, it was very interesting. A lot of patients came in with symptoms related to their implants, and I think it could be because COVID is also an assault on the immune system. And that, coupled with an underlying inflammatory response with implants, exacerbated the problem. So, looking into what causes it. Now, this is a recent study. This is just from a couple months ago, and it's from France. And what they did was they did biopsies of tissues surrounding breast implants, looking at what is the immunologic reaction, what is happening in the tissues surrounding breast implants, and they looked, of course, at different types of breast implants, saline, smooth implants, textured implants. And what we found is that the sources of silicone particles are surface debris. Now, when I say debris, it doesn't necessarily mean that there's contamination of the implant. It's really just the texturing surface of the implant, and those particles are called debris, and that exacerbates an immune response. But there's also gel bleed. Now, this is an implant that I removed, and I'm squeezing it pretty hard and forcing the silicone out, but you can see how even if an implant is not actually ruptured, you can have gel bleed. And one of the things that I've noticed myself taking implants out is very often I'll take an implant out that's completely intact, but if you touch the surface, you can see these strings of silicone just coming off the surface of the implant. And there are studies looking at how much silicone actually bleeds from an implant, and it's found to be about 300 milligrams per year. Now that's actually a very small amount, but if you think about 300 milligrams per year, then it would take 3 years for 1 gram. So it would take about 1,000 years for a 300 gram implant to fully bleed. But the point is that there is microscopic amounts of silicone gel bleeding through the implant. And of course, then you have the actual rupture, which is an immediate exposure to silicone. And this is a slide showing the top 2 lines are looking at saline implants and smooth implants. And they're basically normal histological features of tissue. But then when you get into gel bleed and actual ruptured implants, basically what you're looking at is these big white blobs are macrophages or giant body reaction, foreign body reaction, and these are active reaction of the body to foreign body, to foreign material, to foreign debris. So there's definitely an immune response happening with gel bleed and with ruptured silicone implants and with textured implants, which is why, smooth implants don't have as much of a reaction, but they still do. But the main issue are textured implants and when you have ruptured implants. So there's biopsy-proven study showing that there's a response to these implants. So when you have breast implant-associated illness and you have these issues, what are the treatment options? So obviously you can just take the implant out, but when you do that, there is a cosmetic consequence to that very often. So then what are the options? So it's either putting them back in, which is done but not very common. I have had women choose to do that, especially when they've had ruptured implants with issues. They choose to have them back in, especially the new generation implants, which are more cohesive. The implants today, if you cut them in half, the gel doesn't just leak out. But even the modern implants, over time, they still have gel bleed, like we showed. So there's a combination of approaches of removing the implants, removing that thick capsule that surrounds the implants, but then reconstructing the breast with either a revision lift or fat transfer, which is very popular in my practice because it allows me to replace some of the volume that was lost, but achieve a very soft, natural result. So these are some examples that I'm going to show of what's going on. So this is an example of just implant removal and removal of part of the capsule. Now these were implants that were intact, as you can see, and the patient had very good skin quality. So in cases like that, where the patient has good skin quality, doesn't have stretch marks, doesn't have drooping or ptosis, you can remove the implants, allow the skin envelope to just contract on its own, and you can get a very acceptable cosmetic result. But it's important to also address the surrounding capsule. Now, I want to show you some examples of removing so this is a surgical video showing removal of a ruptured implant. So when we do the dissection, the first thing you're going to encounter is the capsule or that pocket. So that's the implant is contained within a capsule. And I'm sure you've all heard of bloc capsulectomy, removing the capsule and everything in one piece. We're going to show that. But sometimes it's not possible or necessary to do that. And we can do a removal of the implant first. So here you have a ruptured implant, and you can see the gel is just completely ruptured and coming out. So it's important when you do this to remove the entire implant, all of the gel material. And this is an old implant that's 20 plus years old, and you can see how the gel is completely shattered. And that's what causes that really significant immune response, inflammatory response that leads to an immune response surrounding the implant. So that's that patient. I took the implants out, and then you can take the capsule out completely. So it's a complete removal, but it's not in one piece. And the reason for that is sometimes removing the implant in one piece with the capsule can be very technically challenging through a small incision. So it's sometimes a technical issue, and sometimes it's necessary to avoid damaging surrounding tissues, because sometimes these implants that have been in there for a very long time are stuck to the muscle, they're stuck to the rib cage, they're stuck to the lining of the ribs, and yeah, I can tell you things that I've seen that are pretty amazing. So, a complete or en bloc capsulectomy, like I said, is the technique where you do the dissection, where you're removing the capsule completely, like an egg, so that the whole thing's coming out. So this, obviously, I've already done all of the dissection, and you can see how the implant and the capsule and the whole thing is going to come out in one piece. And this was an example of a ruptured implant that we removed in one piece. So that would be an en bloc capsulectomy. So the advantages of an en bloc capsulectomy are that you're removing the thing in one piece so that you're not adding any exposure to silicone. Also, you're avoiding any contamination of the surrounding tissues, because I've removed implants where there was not only the ruptured implant, but also some surrounding murky material. There was cloudy material, milky looking material, mold looking material. I've removed all of those things. So if you suspect any of that and you can do an en bloc capsulectomy, then it's preferable to do that, because sometimes this is what you can have when you had an implant in there for 30 plus years. So what happens, I think, with that is that the implant has been there for 30 plus years. The gel is leaking over time, and then it's creating this inflammatory response. Your body then is attacking that foreign body. It's creating this, it's pretty amazing sometimes what I've found. But that is an example of what can happen when you've had an implant in there for decades. So removing all of that is very important. So this is just some examples of, this is some cloudy, milky fluid that I've removed surrounding an implant. This is an en bloc capsulectomy, and when I removed it, it had these whitish particles which looked like white mold, and the patient also had some symptoms that were very significant. And you can see how the capsule gets very, very tight, rock hard. I mean, this was a round implant. You can see the shape that it has now. So that scar tissue surrounding the implant really distorts the shape of the implant, and because it gets so hard and so distorted, and it is attached to the underlying muscle and the ribs and everything else and the breast tissue, that can cause a lot of pulling and tugging and pain, and especially with movement. So there are a lot of symptoms, physical symptoms, that can be associated with these very, very tight implants. So the disadvantages, like I mentioned, it can be a very difficult operation to try to do this en bloc. And sometimes you can get into real bleeding. That's happened to me when implants are really socked in there, especially because you're operating from an incision under the breast. And sometimes I have to go all the way into the armpit to remove that attachment. And if you get into bleeding there, that's a big problem. And then, of course, when you're doing this, you can damage some muscle because it is attached to the muscle. So of course you do a meticulous dissection, but there is risk of damaging certain tissues. So sometimes it's a better option for me to do what I showed before, which is remove the implant first. Everything kind of softens up, and then I can do the complete dissection and remove the capsule. So is a complete capsulectomy necessary? Because one of the things you'll hear about is, yes, I get this a lot, where patients will come and they'll say, well, I want my implants out and I want the whole capsule out no matter what. And it's sometimes not always possible to do that, because you have to think of the capsule as something that your body made in response to a foreign body. So what your body is trying to do is isolate the foreign body from the rest of you. So it forms a shell, a capsule, isolating that foreign body. And you can get a capsule around a pacemaker, around an artificial knee. Anything artificial in the body will form a capsule. But that capsule, 99% of the time, is very soft, it's glistening, and you don't even know it's there. And when you remove the foreign body, very often the capsule will reabsorb. So it's capsules that are pathological, that mean that are thick or calcified, that definitely need to be removed. But if in removing a capsule you're really going to damage healthy tissue or cause bleeding, it's not always necessary to do that. And this is a study done August of 2023 where it shows that symptoms of breast implant-associated illness resolve whether you remove the complete capsule or not. So doing a complete capsulectomy is not always necessary, but I think in cases where you have a very thick or calcified capsule, as you can see in this example, so the implant's been removed first, and you can see these thick calcified plaques and this really thick layer of tissue. So all that is going to be removed in this case. And I think it's very important to do that in cases of what I call calcified or pathological capsules. So this is an example of removal of an implant with a revision lift. So the patient, obviously her right breast is on the table, the right breast has been done, the left breast not yet. You can see how the implant was in place, but this patient had enough of their own breast tissue that we can just take the implant out, do a revision lift, and get a very nice cosmetic result. So no implant obviously was replaced in this case. This is another example. So just removing the implant and doing a revision lift. So when patients have enough of their own breast tissue, you can get a very nice cosmetic result just by doing implant removal with a lift. Now, fat transfer is a very common technique that I use. So in this case, we've done the revision already, and now I'm going to add fat to the inner part of the breast where there was missing volume and the lower portion of the breast. And the fat is injected, as you can see, right under the skin in that nice healthy layer of fat that you normally have under your skin. So it's injected in very thin layers, and that's going to provide a buffer, additional coverage, and it's a great technique to correct asymmetries or to add volume. I've done primary breast augmentations just using fat, and it's great because you get liposculpting as well, because the fat is usually harvested typically from the back, the waist, the tummy, the inner and outer thighs. So we do some full body sculpting, harvest the fat, prepare the fat, and then you can get some really nice results with fat transfer. So this is an example of explantation with breast lift. This is just at 3 months, and I show this to show that you will have scars that are initially red and visible, but they really improve over time, and by the time it's 6 months to a year, you can barely see those scars. But this is just removing the implants and tightening up the breast pocket by doing a lift. And this patient had a lot of issues where these implants, again, were in there for 20 plus years. They were actually communicating in the middle. She had a communication it's called symptomastia. And also very large, very heavy. And these were removed. I had to reconstruct this area here to reconstruct the cleavage. And then did a revision lift with fat transfer to add volume. You can see how you can get a very nice cosmetic result, a volume that fits her body nicely without implants. Now, obviously, there are more complex cases where this person did choose to have their implants replaced, but these were ruptured implants with a very severe deformity, as you can see on the right breast, with the implant very close to the skin, very palpable. So remove the implants, remove the capsule. She also had motion deformity. When you contract your pec muscles, it moves the implant significantly. So I had to take the muscle down and put it back onto the chest wall, and then do fat all under both breasts, but mostly on the right side to get symmetry. And this is just a good example to show you that fat is truly magical sometimes and what it can achieve using your own tissue. So there are a lot of options when it comes to reconstruction, but I want just a few takeaway points when it comes to breast implant-associated illness. So for the patients, it's key to recognize symptoms that could be related to your breast and not spend years going back and forth getting diagnostic tests and you may have something else, but it's important to consider implants as part of the diagnostic. And there's a lot of information support groups that are out there, but the key thing is really doing a lot of research and doing consultation with a surgeon that, first of all, has a lot of experience with these types of cases, but also believes that this exists. So I think that's an important factor. And then for surgeons, I think it's key for us to educate patients, especially before they get implants, because a lot of women are still getting implants. But I think in my practice, when a patient comes for a consultation, I really educate them as to, all of these things that are related to breast implants. We talk about, picking the right implant for them, but also breast implant-associated illness. Other things like breast implant-associated lymphoma and squamous cell carcinoma, which are different topics to talk about. That's a whole other talk. But these are things that have been reported in the literature with women with breast implants, so it's important to really educate women so that they make an informed decision prior to getting implants. And I also tell them that these are very sturdy devices, but they're not made for a lifetime. And you think if you get implants, you have to think that at some point in your life you're gonna have some revision, replacement, or something done to your implants. But if you pick the right implant for you, so that means that you didn't pick something too big that overstretched the tissue or created a look that wasn't right for your body, then if you do all those things right in the beginning, then you're going to avoid complications. And if you consider exchanging the implants at regular intervals, then you'll avoid having an implant like the one I showed you that was 30 years old. So I think that's important to educate and really have open communication about that in the very beginning. And for doctors, it's also very important to listen to patients, because I can't tell you how many patients I've seen who come to me in consultation and they'll say, I've seen 2 or 3 other physicians, and you're the first person who's actually listening to what I'm saying and believing, where I'm coming from. So I think that's very important. And if a doctor doesn't really specialize in these types of procedures, just like, if I don't specialize in something, I refer my patients to someone who does. So I think breast implant-associated illness is real, and I think it's definitely gaining a lot more awareness now that people are talking about it. But I also have a lot of patients that come to my practice and they'll say, my God, I wasn't aware that I could do this, or I had this available to me. So I think it's important to raise awareness and be part of a group of people that are very aware of what's possible, what can be offered. But it's not just me on the surgery side, but it's also what can be offered to the patient after I remove their implants. And there's a couple of patients of mine in the room today, and I would especially love to hear from Crystal, who has agreed to share her story and kind of her experience through this journey. So you have the floor.
Oh, okay.
Come on up. Thank you.
So I basically match all the darting around almost 9 years worth of testing issues, physical therapy, shots in the shoulder, gut issues. I mean, it just went on and on and on. It wasn't until about 2 years ago that I had a friend who had her implants removed, said, would you consider that this could be something going on? And I was very protective of my female form, and I said, no, that's not going to be me, and thank you, but no thank you. As my symptoms progressed, it became apparent that I was just chasing in the wind, test after test after test. And then when I finally did start going down and looking and getting research, it became very overwhelming. There's a lot of research, but then making sure that when I was doing consultations that I was actually having a doctor who would sit and listen and reflect back to me. So I did interview a lot of surgeons, I did the work, and I was already seeing some different physical therapists, and I will say that I went with my packet of questions to Dr. Polynice and was like, okay, but are you gonna do the M-block? Are you gonna do this? And because I went and I felt empowered, but what I realized quickly is that I didn't feel listened to. And it was the first time somebody walked me through all the alternatives, all the suggestions, all the ways that, yeah, that could be true and this could be true, and have you thought about this? And let's really sit and talk. And it helped me get very calm and looking at what could be different about my body. That combined with a very, I basically created my superhero team, right? So with fascia work, I also recognized that there is a disconnect. When we put in an implant, a foreign body, in this section of our bodies, we're also disconnecting and we're creating, whether or not it's for everybody, but you are creating kind of a barrier, a construction zone between the lower half of your body and the upper half of your body. So if you just think about when everything on a freeway gets down to one lane, and we all love that 101 when it gets to the one lane, things slow down. So when you are having symptoms, and for me it was in the gut, and then there was pelvic pain, and there was digestion pain, and lymphatic swelling, and I was having hip pain, and I was having all of these issues, and then I was having a hard time focusing, and frustrated and nervous, and just this fight or flight. Until I removed that construction zone, I was able to work on lymphatic therapy and fascia therapy, and I discovered that even the vagus nerve, which runs between those two areas, had been completely tight. And that is a foundational piece to us feeling calm. And as a woman who moves through, perimenopause, menopause, you want to be as calm as you can. And so when we're already like running around like this, it completely disrupts that idea of being okay and being calm and being in ease and flow. So understanding that it affects your nervous system, your digestive system, your just entire body, and there's the whole eastern side of how are you helping your heart move with the rest of your body. So just taking into consideration that to normalize this conversation, it's not bad wanting to make something on your body feel beautiful so you can feel on the outside what you want to feel when you're inside, right? You want to express yourself, but doing it with care. And then if you're having those issues, how to make sure you're also able to be with somebody who can walk you through and guide you through, and having that team to help you become that empowered sense of self where you can suddenly go, oh, I can feel safe in this body. Because there's a lot of years that I can tell you I didn't. So having done the surgery and having been nervous about it and waiting a whole year with a lot of questions, there's just a serious sense of safeness and ease and flow, knowing that this body now has just a lot more communication between all areas. So that's my journey.
Well, thank you so much for sharing it. So yeah, I mean, I get, this is one story, but I have dozens of stories like that of patients that have benefited from different procedures where we've removed implants and done some form of reconstruction. So there's definitely a lot that can be done. There's a lot out there, and it's just trying to get the right information. But I was just hoping that this could be a good launching point, because if anybody has any concerns, we have a lot of experts in the room in their different fields that can really address them for you. So thank you very much for coming. I really appreciate it, and hopefully we'll do another one again in the future.
Well, this is
Thank
over.
No, we're going to open it up for discussion and questions.
Additional
Absolutely.
Stories, I think that would be really powerful.
No, the talk part's over now. Questions. So questions, yes.
Oh, I was interested in knowing more about the capsule that you're talking about. You're not talking about the capsule of the implant itself. You're talking about something that the body forms around the implant?
Right, so the implant has a gel on the inside,
Uh-huh.
and then has an outside shell.
Yes.
Now
That's
something,
not considered, that's not the capsule.
that's not the capsule.
Okay.
So, so the word capsule I use to describe what your body made to surround the implant.
Like around a cyst or something.
So you're right. Well, it's a good analogy. So a cyst has it's a cyst content.
Mm-hmm.
It also has a shell,
Mm-hmm.
and sometimes you may have a capsule around a cyst if it's ruptured.
Okay.
But anyway, you have all implants have a shell, and then what's inside them can be different. So you can have an implant that's filled with saline,
Mm-hmm.
or an implant that's filled with silicone.
Mm-hmm.
But something that a lot of people may not know is that whether it's saline or silicone, the shell of the implant is made out of silicone.
Right.
So you're in contact with silicone no matter what implant you have. Then your body's going to form a capsule around the implant, and that capsule is basically scar tissue, like I showed on the image there, that your body forms to isolate the foreign body from the rest of you. Now, in cases of saline implants and smooth implants, you can still get a pretty tight capsule, but it is more common in ruptured implants, because when you have a rupture,
The body's trying to protect itself.
yeah, well, yes, but when you have a rupture, the gel is then, your tissues are exposed to the gel, and that's very inflammatory. And there's going to be a more aggressive response of your body, so you'll form a capsular contracture,
Okay.
which is that hard tightening of that scar tissue. surrounding the implant.
And that's the real work you do when you're in there. When I see you after cases and you come back to the office and you're like, oh my God. Because that part of it, right? That part,
Yeah, it's
removing that was created around.
removing that
implant
is very difficult.
It's very difficult. And you don't know till you get in, like how difficult it's gonna be on each person. So
Right.
it's, yeah.
Yeah, because sometimes you'll get in there and then, well, actually, the thicker the capsule, the easier it is for me to take out, because it's a thicker layer of tissue and I can see it and I can dissect it and take it out. But then there's also sometimes it's really stuck to muscle. And as you're taking it, then you're taking muscles. You have to be careful to dissect the muscle off of the implant, off of the capsule. Then sometimes it's stuck to your rib cage.
That he's come and talked to me about.
And he's just meticulous about that, which is,
Yeah.
I think that's what was so key for me, is that when we had our post-surgical consult, is how much scar tissue
Yeah.
there was wrapped around my rib cage. And so I'm still working with Dara on to releasing scar tissue, because I have nerve pain down my arm, I have, migraines, and I mean, all of this I thought was a shoulder issue, and it really comes down to the scar, and then suddenly the rib cage is trying to protect itself, and it hurt over years. And rolling the shoulders over.
I've had a couple patients where there was ruptured implant, and the silicone had created such an inflammatory response that there was erosion of the tissue between the ribs, and I was looking at the lining of the lung. So it can get really bad. But again, all of these things happen when patients leave implants for decades. This doesn't happen overnight, really. It really takes a long time. But once an implant's ruptured, then yes, you're going to get a very relatively quick response where the capsule is going to get tight very quickly. So that's yeah.
Can you talk a little bit more about the bleed, the silicone bleed?
Yeah.
Is that something, are they like within normal limit, or absolutely like there is no silicone bleed that should happen? You said like, a certain amount. And why does that happen? Is that the shell is not?
That's a good question. So silicone is a very, it's very viscous, obviously. But implants have changed over the years. So the silicone is less, it's more cohesive today. That's why they call them gummy bears, which means that if I cut an implant in half, the gel doesn't leak out. Like an implant from 30 years ago, like a couple of ones I showed, if you cut it in half, it oozes out. It's more liquid. But I remember reading somewhere that if you left a blob of silicone on any surface and you came back 100 years later, it would have seeped through the surface.
Oh.
So it's very, I don't know what the word is for it.
So it's the molecule is
It's
such
the
that
molecule is
it
such
goes
that
through.
yeah.
Got it.
Now, the implants from 30 years ago, I think, had much more bleed than the ones today. Like if I take an implant out that's 20 plus years old, even if it's intact, you put your hand on it and you lift your hand, you see strands of silicone connected to your hand. A modern implant doesn't do that, but then again, a modern implant hasn't had 30 years yet. So I don't know how much bleed you'll get with the modern implants, but there's definitely a factor of implant gel bleed. But again, the one study I quoted did say 300 milligrams, which may sound like a lot, but you have to take a standard implant of, let's say, 300 cc's, that weighs about 300 grams. So it's 1 gram for 3 years. So it'll take 1,000 years for all the gel to bleed out.
Yeah, but like we talk about inflammation, it doesn't matter, right? Even if it's one molecule and
But for inflammatory purposes,
Yeah.
300 milligrams is plenty to cause an inflammatory response. So you do get an inflammatory response in every person that has an implant, because that's what causes the capsule to form. It's the inflammatory response to the foreign body. That's where you have those macrophages, but the response is less in a smooth implant or a non-ruptured implant, but the minute you have that rupture or that bleed, then it's an aggressive response. And then you get a really thick capsule. That's the inflammatory response, but then the immunogenic response, where studies have shown that there's spikes in immunoglobulin E and all of those immunoglobulins that you would see in an allergic response. So you do see that in women with breast implant-associated illness. So
my implants were completely intact when I took them out. Like I thought there would be something wrong with them just because my sickness was so bad, but I still had the response even though they looked fine 8
intact,
years later.
right.
When did you start feeling sick?
About a year and a half in, but the symptoms started slowly. So I started having severe insomnia, and then I started having joint pain, and then I started having chronic infections, and just like they compounded.
Yeah. So it took 8 years to get them.
To figure it out, I saw like dozens of different doctors and practitioners. I had so many tests done, and they would come back normal, and they'd say everything's normal, you're fine. And I'm thinking, I'm in pain, I have all these things going on, there's got to be something.
Yeah.
And I finally read an article where a woman with similar symptoms had her breast implants taken out, and they were covered in mold. And so then I thought that could be my issue too. But I talked to a few surgeons that kind of blew me off and made me feel like it wasn't a thing. And then luckily I connected with Dr. Polynice, who listened, and literally the day after he took out my implants, my joint pain was gone.
Wow. That's amazing.
So you see, you cannot deny stories like that, and I hear them all the time. So I tell patients when they come to me, I said, you have no other diagnosis that can justify these symptoms. It may be related to your implants, but I say, I have had cases where I've removed breast implants and the symptoms have persisted. But the great majority of my patients who've come with these issues have benefited from implant removal. Yeah.
Well, I was just gonna mention too, like working with Dr. Polynice, we've had patients that come in 2 days later for their post-op, and their skin, everything they look more alive. And that's just 2 days with them out. So
Yeah.
it's amazing. But I was gonna ask you, Dr. Polynice, why do some women contract and some don't? Because that is I think I know the answer, but maybe for other people they might not know. But why some women have more capsular contraction?
There is no good answer to that, because even in women who, first of all, out of all the people that get breast implants, about 5 to 8% of them will form, 100% of them will form a capsule. Everybody gets a capsule. But about 5 to 8% of them will form a capsular contracture, which is where that capsule becomes tight. And sometimes most often actually it's only on one side. So why not both sides? Because we did the same operation on both sides, the same exact way, but one side gets it, the other side doesn't. I don't have the answer to that. We don't really know what causes capsular contracture. It could be surface contaminants, but in my hands, what I try to do is to avoid any kind of possible contamination. By contamination, you mean just exposure. For example, you wouldn't open an implant and let it sit on the OR table before putting it into the patient. So we use gloves that don't have powder. We wash everything with antibiotic solution. Wash the pocket with antibiotic solution. The implant isn't open until it's ready to go in. And even then, it's put in with a special funnel. I don't even touch it, minimally. And then as soon as you put it in, you close the pocket. So the implant is exposed to air for maybe 20 seconds. Because but even with all that, I still get capsular contraction. So, but I think in my experience, it's much lower, but I think it's probably related to the individual person and how strong of an immune response they have to the foreign body. Yeah. So, but again, I can't explain why it only happens on one side in certain people, and not on it. It's almost never on both sides. It's just one. Yeah. Go ahead.
Once you have a leaky silicone implant and then you develop an autoimmune disease, is that treatable, or do you need to, even if I had other implants placed since then and I still have an autoimmune disease, if I took my implants out, would that somehow correct the autoimmune disease?
Gosh, that's a great,
Permanent.
that's a great question. Obviously, there are women with implants who also have an autoimmune disease. So I think that women with breast implants, if they have an autoimmune disease, may have an exaggerated response to because it's another attack on the immune system. So removing the implants may help in some regard, but it wouldn't cure the underlying autoimmune disease. But it may improve the overall symptoms that someone's having. Because you're having a sort of a dual encroachment upon the immune system. So definitely removing one would help, but it wouldn't fix the underlying problem. So for example, somebody with Sjogren's syndrome or somebody with an actual autoimmune illness may have worse symptoms with implants in place, but removing the implants wouldn't cure the underlying problem. Yeah.
Could you speak a little bit more when Carly mentioned that she had the mold issue with her implants, and you had mentioned it before, and I treat a lot of people, I think it was it you?
No,
I'm
Sarah.
sorry, I'm sorry.
I didn't actually have
No,
that
she
in
didn't
mind,
actually
but
have it.
She
She
saw
Somebody else.
Okay,
somebody else.
anyway, the mold issue, all right, because that's completely new to me, and in my lymphatic therapy practice, I run into a lot of people with mold issues, and often they're going, I don't know where it comes from, there's no mold in my house, I've had everything tested, and this is a whole new piece of information that I've been exposed to that now it would probably be good for me to, because I know whether or not they have breast implants because of the way I'm treating them.
Right.
So that would be, so does the mold come from the implant itself? Or is it, they're exposed to mold and that's where it chooses to?
Right. I've only had one situation where I found moldy, what appeared to be mold in an implant. And it was a saline implant that had been in for decades. And typically when you remove a saline implant, if they're intact, the saline inside still looks clear.
Mm.
But this one had cloudy patches within the fluid that turned out to be mold. But that was not, I guess, technically related to the implant. It was related to the saline that was in the implant.
Okay.
And then the other image that I showed that had the white patches that appeared moldy, they were calcifications, they weren't actually mold. So I've only had one true mold case,
Okay.
but that was in a saline implant.
Okay, but would that be something to maybe to mention to a patient that has unexplained mold symptoms and has breast implants?
I think it's definitely something to consider, especially if they've been in for
Long
a
time.
number of years.
Okay.
And that's, I think, where I think the primary care physicians come into play, because I think they need to be more aware of possible symptoms that women have that could be related to breast implants. Not to discount any of the other things that you want to look into. You want to do your immune, check your immune system. You want to make sure you have allergy testing. Do all of the things that you normally do, but don't discount breast implants.
Very interesting.
Yeah.
I think it would be really important to find out how long they've had them, asking those questions, because, it could possibly.
I've only had one patient come in, I forget if it was one of you, but one patient come and tell me that they saw their primary care physician who actually said, oh, you've had implants for this one, it was you.
Yeah, but that's
So you
after
did-
8 years of
after-
me seeing doctors, and I was like, oh, a new doctor finally asked, and she's younger, decided, and so I think, again, going back to the previous part of your conversation and your, talk tonight is, how do we normalize this? Because when you're going to your doctor and you're having an issue and, it's like, are you pregnant? Are you, those questions they ask us as women. I think implants need to be part of that conversation because it affects our hormones, it affects our blood work, it affects so many things. So why not normalize it within any of the doctor visits you're having so that you give yourself a chance to really get to the root issue?
I think that's a good idea, and I'm gonna put Duncan Turner on the spot here. When you do your breast exams with implants, you have these conversations.
I actually do ask how long they've been in there, and certainly whether there's any calcification or strictures or anything. I see if they have any symptoms from that. But I don't routinely ask about immunological illnesses, autoimmune illnesses, just because they have implants. Although, I take the hint.
Yeah, but like, what if we changed our paperwork, Charlie?
I think that's a good idea
Yeah,
because
like, do you have breast implants? If so, are you experiencing?
I think so. I think that's a great way to get the conversation started.
Mm-hmm.
Because it is still a stigma. Plastic surgery is a stigma. Women
Yeah.
feel judged.
Mhm.
We don't judge, but the information needs to be out there because it is a possibility.
And our patients are pretty used to having inpatient paperwork that is even more suggestive than that of how their clinical sensation is. So I don't think they would be upset if you ask them their problem with this.
Okay. Let's do that. We'll add that.
Yeah, I think making that a regular topic of conversation in any doctor's office is really key.
Yeah,
Yeah.
absolutely.
Well, and becoming
question?
more aware.
No, I have a comment. Going back to the primary care physician, my primary care physician actually mentioned my blood work to me. And then when she did full panel and tested my ANA, it was elevated. But she had a patient a month prior, with the same elevation who also had breast implants. So
Interesting.
both our markers were identical elevation with the breast implants. So I just wanted to make a comment on that.
That's a very good point. And ANA is definitely a marker. It's not a definitive diagnosis of anything, but it's definitely something that you would delve and investigate more to see what else is going on.
What
as
is
far as
ANA?
No, it's any.
Autoimmune.
it's an autoimmune marker in a blood work.
Oh,
Sometimes an indicator of like rheumatoid arthritis and things like that. So ANA levels would be elevated when an autoimmune process is going on.
I think it's good to understand how to approach even a general practitioner with saying, hey, I went to this talk, I did this thing, could we look at these levels? I mean, because I think again, normalizing the conversation, like Carly's saying, it's such a stigma, but how do we help bridge that, so we can go to a regular doctor, ask some questions, ask for their help to get maybe some paperwork that helps us more, make a direct link, because otherwise, we all share this story of like 10 years later, I mean, it's like we're trauma bonded. It's just, it's a long journey, it's an expensive journey. And by the time we're getting to you, we're all exhausted emotionally, physically, financially. So it's how do we shorten that time frame so that we can really heal?
I had 3 procedures done in 4 years, thinking the first or the second one would make me better, but it just wasn't the right path, so that is the right path, right there.
Yeah.
You're so kind. But I'm so happy that you finally, you're feeling better, symptoms improving. I mean, these are all great stories, and that's why I do what I do. So, thank you. Yeah.
You were saying that if you take the implants out, it won't necessarily cure the autoimmune disease, but having the implants put in could cause the autoimmune disease.
Having implants put in you can cause an autoimmune reaction in the body that can be symptomatic, and you can have some of the symptoms that we talked about today. But I think the question was having an actual autoimmune disease that you would have regardless of implants. So
I had implants in 2020,
Uh-huh.
and since then I've been diagnosed with Hashimoto's.
thyroiditis, yeah.
I think each of us had autoimmune symptoms like hair falling out, skin issues, and I luckily didn't become an autoimmune disease, but definitely had a lot of the symptoms. And I do wonder if they'd been left in longer if I would have developed an autoimmune disease, because I just was getting worse and worse and worse, and by the end couldn't even get out of bed. It was awful.
It's really tough to say whether or not someone would have gotten Hashimoto's without the implants down the road. And it's really hard to pinpoint the timeline of all that. But clearly, once you have a diagnosed autoimmune issue, and you have, I guess, implants compounding the issue with autoimmune inflammatory responses, that's where it can get worse. So that's where I say, I can't guarantee or promise that removing implants would fix that problem, because I'm not sure that it was contributing to that problem. It's really a hard thing. Yeah. But all good things to consider. you have another question?
Oh, me? No.
Yeah, because I see you wrote a lot of things down.
I was also taking notes, there were no.
Okay, all right.
So much information
Yeah,
that this was totally worth my time instead of being with my girlfriends.
Well, I appreciate it. Hopefully everybody got something out of it, but listen, I think this is the first step in the conversation that can be ongoing. Yeah.
Well, I have read that the breast explant surgeries are now the most popular elective cosmetic surgery there is. I don't know if that's.
It's, in my practice, yeah, I get way more consults now for explantation, removal of implants than I do for putting
And
implants
the
in.
AMA has now recognized breast implant illness as a legitimate illness.
There's definitely much more, as you can see, there's been studies ongoing, and recent studies really showing a relationship between implants and these issues with the immune system and these symptoms, so yeah.
And I will say that I've been a lymphatic therapist for almost 20 years, and especially in the last 5 years or so, I will say probably 80% of the women that I treat that have breast implants volunteer to me that they wish they'd never had it done.
80%?
A vast majority. I only did it because my husband wanted big boobs.
Oh, I have a question.
Yeah, let's blame the guy.
Yeah.
That's right.
I'm not saying that.
Since the AMA is recognizing that, is there any chance that you could have insurance pay for the extraction of the implant?
That's a good question, and it's probably gonna head that, I mean, right now, there are certain situations where you can have insurance cover removal of ruptured implant causing significant symptoms.
But
Already.
it has to be ruptured.
It has to be ruptured, and you have to have, but obviously,
How many times could I fall?
yeah, trauma or proven rupture. So if you have an MRI that shows that you have a ruptured implant and you have symptoms, and there you can make a case and have insurance cover the removal. But that's all they'll cover, is the removal of the implant and the scar tissue. No. So anything that involves revision, lift, or fat transfer, or anything that needs to be done to create a nice cosmetic outcome, they wouldn't cover that.
Oh, can you talk about implants after radiation?
Ah, well, that's a whole other topic. Like, obviously.
I just wanted to mention it because that had come up from my friend too.
So you're saying implants after? So women who have implants and then get radiation.
No, so women who have breast cancer
Get radiation.
and get radiation are at a higher risk of breast implant illness.
Oh.
That's what I'd heard.
Well, that's a tricky one, because women who get breast reconstruction with implants, compared to women on the cosmetic side, the reconstructive side has a higher incidence of complications in general. Higher incidence of capsular contracture, malformation, deformity, unevenness. I'd have to really research that to see if the incidence of breast implant-associated illness symptoms is higher in that category. I don't know, but the complication rate is higher. And if you add radiation on top of that, that's almost 100% guarantee that you're gonna get a capsular contracture because the tissues surrounding the implant just contract on their own. So, yeah.
How is it doing surgery in that area that has already been radiated and the skin is so compromised?
That's, well, if you don't have implants and you get breast cancer, mastectomy, radiation, then it's almost impossible to do an implant reconstruction then.
Right.
So in those cases, you would have to have other options for reconstruction using autologous tissue, like a flap, a tram flap, or.
Can you do fat transfer in that kind of tissue, or does it not say where you want it?
That's a very interesting point. I have done fat transfer in radiated breasts to correct contour deformities, and it's worked really well because, but again, we're talking correcting minor deformities.
Right.
But because the fat, when you transfer the fat, I've noticed that the fat actually, when it takes, creating its own blood supply improves the skin quality.
Oh,
So I've had good results with fat transfer in radiated breast.
Wouldn't that be interesting if you could address the skin issues themselves with like slight fat transfers or something to bring it back to normal?
So fat is pretty amazing. I love fat.
Other people don't even know it's an option. It's so funny
No,
when they
they
come
don't.
in. It's really exciting for women who don't want implants, and then it's a
Can
great,
we
great
donate
option.
I get that question a lot too. So the answer is no, obviously, unless
Why not?
you have an
I'll
identical twin.
volunteer. Yeah, right.
If you have an identical twin, technically
Listen, I
you
can
could.
donate an organ or make that
Is it just a fat that's absorbed eventually or something like, you know?
Yeah, you do reabsorb some of the fat. So the fat is basically it's a transplant. I'm transplanting a cell from one place to another. So for that cell to survive, it needs to be in contact with healthy tissue and healthy blood supply. So that's why there's a limit to how much fat you can transfer, because if you crowd the cells, if you put too much, then they're not in contact with healthy blood supply, and the fat cells will die. So they'll form either a fatty cyst or fat necrosis. The fat cells will die, and you don't want that. So you have to have healthy tissue doing small amounts of fat transfer, which is why in cases sometimes where I need a lot of volume of fat, you may do more than one session.
Do you have to, when you do the fat transfer, and I know you're not supposed to manipulate that fat, but in my case, for a month, we don't
Right.
mess with anything. Is that to allow that fat to develop a vascular, to develop
Correct.
a blood supply, and once it's done that, then it's a little more stable?
That's exactly right.
Will that form a capsule? Or
No.
what? It won't.
Because it's not a foreign body.
Exactly.
Ah.
So we'll
So
stay.
there's no reason for your body to encapsulate it.
If someone's
However,
got fat loss,
If
diet,
the
or
fat
problem-
dies and becomes fat necrosis,
Oh,
that may form a capsule, because then that's a
foreign.
dead fat. But yeah, it's a very good question. So no, just doing a fat transfer of your own fat works great, and you don't form a capsule. No.
And
Yeah.
from, you can take it from any part of the body and put it anywhere else, and it's the same. type of
Yeah,
fat?
I take it from everywhere. Back, arms, abdomen, thighs, waist. You can take fat from anywhere. And very often I have to take it from a lot of different areas, because if I need a lot of fat, you can't just focus on one area, then you can create contour deformity. So you have to sculpt the body, harvest the fat and evenly from everywhere so that you have a nice outcome.
What if you don't have a lot of fat?
That's a problem. That is a problem.
You need to
That is a
gain
problem.
weight.
It is true that,
Can you actually do that, like gain weight on purpose?
oh yeah, people do that.
People do that.
Enjoy the pita bread?
Yeah. No, you can't, because it's true that I'm limited, obviously, by how much fat you have. And I have patients who come with zero body fat. You pinch their skin, there's absolutely nothing there. There's nothing to work with, you know. So that's a problem. So that's why in some cases I have to harvest fat from. Harvesting the fat takes longer than the rest of the operation.
So you could like gain weight, have the fat taken out and then stored and then gain more weight.
Yeah, I wish you
I don't think
could.
you want to store it. I think
No,
you
there's no
use it
fat
for-
storage. You'd have to use it right away. Yeah. Yeah.
So you talked about the complications of having the implants in. What's the biggest thing you're having about?
Exactly.
Well, I mean, there's no complication of having them out other than the cosmetic result of taking them out. So that's why, you know, reconstructive options, revision options, fat transfer. But literally removing the implants, there's no real complications.
It's so fast too.
Yeah.
Comes in and out.
There can be
You
like
work.
sometimes an emotional component.
Well,
Well, yeah.
yes, there is an emotional component. That's, I think, a reason why a lot of women choose not to do anything, even though they're having symptoms and concerns. The thought of not having the implants or the cosmetic consequence, especially with women who had very little breast tissue to begin with, and they know that, and they know that the majority of their breast is from the implant, and that when we take those out, it's going to be completely deflated. That's why I have a few women who have implants, they've had symptoms, they know they're ruptured, but they choose to have new implants put in because there's no other option. There's no fat to be had, and there's no other way to restore that volume. So exchanging the implants, knowing that you're still putting a foreign body in, but at least it's a brand new implant, it's not ruptured, we know about texture now, we know that the new implants are more cohesive, they have less bleed, so there's a lot of benefits to the new generation implants compared to the ones from 20 years ago. So some women do still go the route of, because they have no other option. Unless we have artificial fat, which we don't have yet. Actually, we do have artificial fat, but it's so expensive and you have to use so much of it that it's
Can't we 3D print it?
prohibitive.
Right?
It would be prohibitively expensive.
I will say one thing that I was really vocal with Carly and Dr. Polynice is the surgery itself is a first step of a recovery, and making sure that there's kind of the emotional component, there's a lymphatic component, there's the fascia component, there's, so for certain people, there's the detox component, so there's, you know, red light therapy or sauna, or so making the decision of not only having this surgery, but maybe having the chance to talk with somebody to guide you through it, I think is a really important thing. I made sure I understood it and then had somebody to kind of, you know, like, what are you going to expect? I mean, I went through an emotional roller coaster, way better on the other side though.
Yeah, that's so true. That's why we're kind of putting together a network of providers from massage therapy, fascia release therapy, red light therapy, hyperbaric oxygen therapy, IV therapy. So all of those things are, you know, synergistic, so to speak, and they really help in the post-operative recovery.
I personally find that one thing I hear the most now, or one thing I'm noticing, is that what do I do next? And Crystal and I have talked about this. You know, I have patients that either have them out, but I still feel a little like they need that mental support, and that's something that Crystal and I are kind of working on and have started to. And you know, we're very grateful for her for introducing us to Dr. Dara and having this community, because that's really like afterwards they don't know what to do.
Yeah.
It's very important.
I think this was great. It's a great conversation. So glad we all got to meet, and now there's kind of a mini introduction, so you know that the network's available and the resources are there, so it's all great. Thanks for coming.
And there's
Wonderful.
a little